I am going to present a case of syndromic genetic aortopathy that I visited the patient more than 15 years ago, and there are probably some aspects that, viewed from today, might have been handled differently, but I think this can be of great interest to learn a bit from the mistakes. This is about a 29-year-old patient. Her father had a diagnosis of Marfan syndrome with type A aortic dissection, who underwent surgery at 46. Several members of the paternal family were diagnosed of ascending aortic dilation. Some members had experienced aortic dissection, 2 uncles, and there was another brother of the father, a paternal uncle, who had also been diagnosed with aortic disease and had suffered a sudden death. Her family were some in Japan and some in Mexico. That is, no other first-degree relatives live in Barcelona, in our city. With the diagnosis of Marfan syndrome, the patient came to our unit for her first appointment. She told us she was diagnosed with this disease and that she had a slight dilation of the aortic root that was diagnosed approximately 5 years ago. In the second visit, we did not identify any changes, but she told us her wish to be pregnant. She wished to have kids, so we indicated an echocardiogram. The echocardiogram revealed dilation of the aortic root of 43 meters with a Z-score of 4. But at that time, we explained the intermediate risk of the pregnancy, but she insisted with the pregnancy, and we accepted as diameter was lower than 45 mm. Therefore, it seemed enough to us, but we indicated a genetic test. Surprisingly, it was negative for fibrillin mutation. Genetic studies at that time were individual tests for each disease. We did not have aorta panel, so we tested gene by gene, and the fibrillin was negative, and the MLPA results were also negative, which made us classify her as a Marfan syndrome case with negative genetics, since there is a percentage of cases that can be like this. That is, over 5% of diagnosed Marfans have negative genetic test. We outlined the risks, explained the controls, we provided pharmacological treatment, and said we would continue to follow her. And the patient was booked for follow-up in 1 year because the patient was not pregnant at that time and there were no risk factors in her current evolution. Well, focusing a bit on the diagnosis of Marfan syndrome, we could say that with the family history of Marfan syndrome, simply with the aortic dilation and the Z-score that she had, she already met the criteria for the disease. There was no need to search much more. If we had not a family history of Marfan syndrome, things might have been different. Or with a Marfan diagnosis, it would have been different. Maybe if the ophthalmological examination had shown ectopia lentis, which the patient did not exhibit, it would not have been enough. Then the mutation of fibrillin had not shown up either. It would not have been sufficient. But in any case, if we were to have a Z-score high of aortic dilation, but we also had systemic involvement with a score of more than 7 points, as it would have also met the criteria for Marfan syndrome. So we conducted the physical examination of the patient. Physical examination showed a systemic score of 7. She exhibited the wrist and thumb sign, indicating 3 points. She had a pectus excavatum, indicating 1 point. No other data were present, but she had scoliosis, which implied 1 point. She had noticeable skin striae, indicating 1 point. She had mitral prolapse, which also counted for 1 point. Therefore, we already had musculoskeletal criteria and aortic dilation. This allowed us to establish the clinical diagnosis of Marfan syndrome, even without a family history, which she actually had. Well, 6 months later, the patient came back and informed us she was pregnant. We repeated the echo, confirming the same diameters with an aortic root of 43. No other data was seen at that time. She had a small mitral prolapse and the tubular aorta, the arch and the abdominal descending aorta at the subxiphoid level appeared normal. She was referred to the high-risk pregnancy unit for closer evaluation, and we arranged for quarterly follow-ups. We recommended atenolol, and she kept her blood pressure well controlled under 120 millimeters of mercury. Well, the pregnancy was normal, but at 30 weeks into the pregnancy, following an obstetric ultrasound that was done, we were notified that a thrombosed aneurysm had been diagnosed in the abdominal aorta. A magnetic resonance imaging was done, which indeed reported the abdominal aneurysm, starting just below the mesenteric artery, extending to the aortic bifurcation with a maximum diameter of 58 millimeters, and had a thrombus on its wall associated with this dilation. The aorta, specifically the aortic root, showed greater dilation of 43, now measured at 45 by MRI. This means we can see that there is an aneurysm with a thrombus in its wall. The patient was pregnant. Here we can also see the image with white blood from the MRI, and here we see the maximum dilation of the aortic root, which was 45 millimeters at that time. Considering this significant dilation of 58 millimeters of the abdominal aorta, we were quite alarmed. The patient was admitted, and given that she was at 30 weeks, we waited until 32 weeks. We held a meeting of the aorta team. We discussed the case with cardiovascular surgeons and the obstetricians who monitored pregnancy. Finally, we decided to indicate a cesarean section. The child seemed to be viable and healthy. At 32 weeks, a cesarean section was carried out without complications. The child was born healthy but required to be in an incubator 5 days, but right away everything evolved properly. 2 days post-cesarean, the patient underwent an angio-CT. In this study, you can see quite well that the thoracic aorta was slightly dilated and elongated, and significant aneurysm in the abdominal descending aorta with a large thrombus. And here you can also see the axial projections very clearly. We have confirmed the diagnosis, and then we set the treatment plan. A surgical option was suggested, and the patient was operated on. A resection of the abdominal aortic aneurysm was performed. A 20 millimeter Dacron graft was placed from the distal thoracic aorta to the iliac bifurcation. A quadruple bypass was necessary for the celiac trunk, superior mesenteric artery, and left renal artery. The post-operative period was somewhat complicated. The patient required multiple transfusions, nutritional support, and continuous hemofiltration for acute renal failure. Therefore, When we performed the surgery, we believed everything went smoothly, but the post-operative period turned out to be much more complicated than we had anticipated. This resulted in the patient staying in intensive care longer. On the 17th day after surgery, she presented back pain due to acute retrograde dissection in the thoracic aorta. Therefore, after the abdominal aorta surgery, the thoracic aorta dissected backward until the left subclavian artery level. Given this critical situation, it was decided against performing open surgery because the patient was, as I mentioned before, very unstable and vulnerable. An emergency endovascular procedure in the thoracic aorta was indicated. TEVAR was uncomplicated, and the patient evolved adequately, but very slowly. Overall, the patient spent almost 3 months in the hospital before being discharged in an acceptable general condition, but with renal failure that required dialysis, as we will discuss. Thus, the patient had undergone surgery for an abdominal aortic aneurysm and had an endoprosthesis placed in the descending thoracic aorta. The angio-CT performed at 3 months after discharge showed that even before discharge, it was clear that results were not quite right. The arch angle was very acute, and in this area, the stent was not well positioned over the inner part of the aortic arch, leading to a type 1 leak that grew larger over 3 months, measuring 31 millimeters. Thus, we started worrying about what actions to take for the patient. She was in a position where she didn't accept in anything more. She was with her child, but she was on dialysis, still very weak and anemic. Thus, we understood the situation and proceeded without patient monitoring. The severe kidney failure, which required chronic hemodialysis and ultimately enabled her to accept a kidney transplant. The kidney transplant was performed 1.5 years after giving birth, with kidney function that was, she healed nicely. We repeated the genetic test with an aorta panel, and it revealed a mutation in the TGF-beta receptor 2. At that time, the patient's evolution was quite growing the size of this located aorta aneurysm, and this made us uneasy, but the patient resisted. Even after the transplant and good kidney function, she was unwilling to pursue any additional aorta treatment since she felt mostly asymptomatic. She was a bit weak but asymptomatic, and perhaps she needed to continue treatment for anemia because she was making notable positive progress. In the follow-up controls by CT scans, we saw that the aneurysm was stable, but increasing in size very slowly. You can compare the size from the discharge study to the last follow-up scan. The aneurysm was increasing in size, although the patient was not deteriorating. It was impossible for us to convince the patient. Subsequently, we observed that in the follow-up, the CT scans done 3 years later, the aortic root that measured 43 at the start, but it had dilated, and we were dealing with an aorta measuring approximately 48, depending on the view. It was over 52 millimeters. We now understand that the diagnosis was no longer Marfan, but a Loeys-Dietz, specifically a Loeys-Dietz with a mutation in the TGF-beta receptor 2. This implies treatment for the aortic root, which we know surgery should be indicated at 45 millimeters or even 40 millimeters. Here you can observe by CT the significant progression of the aortic root dilation during these 3-year follow-up. which led us to propose surgery of the ascending aorta, arch and proximal descending aorta to solve also the residual aortic root and aneurysm located in the proximal part of the endoprosthesis. However, the patient was asymptomatic and refused this option. The patient had gone through a quite traumatic experience with 3 months of postpartum hospitalization, and in the end, the only surgery she agreed was a David procedure in ascending aorta, which was done without complications. There was no aortic insufficiency, and follow-ups were carried out. She was receiving treatment with losartan 50 mg per day, with normal renal function. We couldn't raise the treatment because she had a tendency for hypotension that she didn't tolerate well neath the additional atenolol, so we left it. We followed the patient every 6 months, until eventually we noted a significant enlargement of the aortic arch and the aneurysm, and we convinced her after this long period of time to undergo aortic arch surgery, performing a complete arch repair with replacement of the supraaortic branches. In addition, the aneurysm caused by the type 1 endoleak was excluded. The evolution after this surgery was perfect. I have been following her personally, and after 14 years since her pregnancy began, and she was admitted due to the abdominal aneurysm, she is doing well without complications, and at the moment she is stable both in her aorta and in her general condition, and her kidney transplant is functioning well. Her son has also been affected by Loeys-Dietz due to the TGFV receptor 2 mutation, but at this moment he is 14 years old, controlled in our unit, and has not expressed any problems. It should be noted that we have performed MRIs in our patient and evaluated her entire body, and she has some minor tortuosity in the supraaortic trunks, as well as in the intracranial arteries, but no aneurysms or other issues have developed. So, well, I would like to emphasize what we perhaps didn't know 15 years ago. There is an overlap in groups of patients who have features of Marfan syndrome and Loeys-Dietz related to the TGFV receptor 2, like this patient, and they may have significant musculoskeletal involvement in these patients. Marfan features in patients who are truly Loeys-Dietz with TGFV receptor 2. In this series from the Paris group, Dr. Yundo published that 31% of the patients showed no musculoskeletal involvement of any kind, but the others did exhibit such abnormalities. This means we had a high rate of patients with musculoskeletal findings similar to Marfan, and 10% of the patients in this series from the Paris group met the criteria for Marfan, so it was a major musculoskeletal criterion. There are 10% of patients with Loeys-Dietz who have a mutation in the TGFV receptor 2, who satisfy the musculoskeletal criteria for Marfan syndrome, and this is crucial to remember because in that case, we didn't perform a complete panel evaluation, and the Marfan genetics tested negative, so we thought the genetics were negative, but we didn't consider the possibility of this other mutation. And it's important because, you know, the TGFV receptor 2 has surgical criteria starting at 45 millimeters and with risk factors up to 40 millimeters, so we wouldn't have permitted her to get pregnant back then, and we would have taken different actions, but this was 15 years ago when we didn't have evidence as we have today. For example, here we have the list of musculoskeletal involvement from the Paris group series. We can see that there are clear differences between patients. Pectus carinatum is more typical in Marfan, the high arched palate is more typical in Marfan, and possibly scoliosis is too. But all of this is also present in the TGFV receptor too. We can observe that height is higher in Marfan, but it's not low in TGFV patients, and in addition, we can observe that patients with Marfan have longer arms. We have to note that ocular involvement is more prevalent in Marfan, and we find that stria are more frequent in the Marfan, but TGFV receptor 2 and dural lactasia are also seen more often in Marfan, but they exist as well. Thus, there's an overlap that doesn't let us conclude that positive musculoskeletal criteria indicate Marfan and not other genetic conditions of genetic aortopathy. To conclude, I would like to summarize this case by first highlighting the importance of clinical diagnosis and adding genetic study, especially nowadays, as panels are now much more affordable. It's easier to do a panel study than to analyze gene by gene, thus this is a fact. This study clearly indicates that we could have diagnosed this patient 15 years ago, and we had changed the management if we had access to a panel and not starting with fibrillin, despite the family was already diagnosed of Marfan syndrome. A clinical non-genetic diagnosis was made for the family with the same diagnostic approach to our patient, which probably had a Loeys-Dietz syndrome with a mutation in the TGFV receptor 2. On the other hand, the important lesson from this case is that we were stuck back then seeing that the root was dilated with 43 millimeters, but at that time the cutoff value was 45 millimeters then, and we didn't study the distal aorta by CT or MRI. Before pregnancy, the whole aorta should be assessed. We don't know the condition of the abdominal aorta before she got pregnant, nor do we know if she developed this abdominal aortic aneurysm during the pregnancy. But today it is clear that we must conduct a complete study of the aorta and not just rely on echocardiography for the size of the root of the aorta. Obviously, it is important to stress that genetic aortic pathology does not only occur at the root of the aorta, and some patients develop dilation or dissection of the thoracic descending aorta or abdominal aorta, as in this case that began with an abdominal aortic aneurysm, which is not unusual during pregnancies. We don't really know why this is, whether it's due to flow or something else, but I have a few cases of progressive aneurysm dilation or dissection during pregnancies in the abdominal aorta. Take this into account. Finally, the management of the aneurysm was to try to reach 32 weeks to, if feasible, to ensure the baby's viability and then act right away. Sometimes this is feasible, sometimes it is not, but when it is feasible, it's crucial for the aorta team to handle this matter and evaluate the risk or how it can be approached. Sometimes we need to admit the patient in for several weeks, as we did. Another aspect, another lesson, is endovascular treatment. In genetic aortic conditions, endovascular treatment is not always a good option. In emergencies, such as this case, where dissection happened after abdominal aorta surgery, the entire thoracic aorta dissected, we found ourselves unable to perform an emergency open surgery. But notice that this endoluminal approach gave us a proximal local aneurysm and how it has developed other complications at various levels of the aorta, ranging from the ascending aorta to the aortic arch. Therefore, when we have a pathology that extends across different segments, the recommendation might be to conduct open surgery that addresses all possible segments. Today, there are skilled teams that can perform ascending aorta surgeries with excellent results. And using Toraflex or Sienna, we can proceed by placing an elephant trunk in the descending aorta and then ultimately operate on the whole descending aorta. Therefore, we made several mistakes 15 years ago, and we had managed in a different way, but there have been very significant advances in this disease. Learning from mistakes makes us progress. Many thanks.